Our next presenting company will be Everfront Biotech Inc. and presenting will be Adrian Lee, the director.
Thank you, Pan, and thank you everyone for joining this meeting. I am Adrian Lee, Director of Medical Affairs at Everfront Biotech. We based in Taipei, Taiwan, and today I will show how our product, cell-blocker wafer, treat the delicate between the brain surgery and adjuvant treatment. Glioblastoma is one of the most lethal cancers we know. The median survival is only 61 months. It's truly never it's because the resection truly never complete. There are residual infiltrated tumors extend to 2 to 3 centimeters. However, the current drug, glial wafer, only penetrate 2 to 3 millimeters. That's a big gap. So if the residual zone is exactly where the patient relapse, is also exactly where the drug cannot reach. So we establish a platform. It's a biodegradable implant platform that converts surgery itself into therapy. There are 2 components. It's a FDA-approved biodegradable, biocompatible excipient, and our proprietary new chemical entity, receptor tyrosine kinase inhibitor. We combine them and manufacture the cell-blocker wafer. So neurosurgeon or surgeon directly put it into the resection cavity, and the drug delivered in a 30-day sustained release for high local drug concentration, and it can be administered to the solid tumor, brain cancer, beyond that, expand pancreatic or spinal tumor. Glioblastoma failed to some challenges, blood-brain barrier, block systemic treatment. Glial wafer bypassing locally, and glioma also is driven by the receptor tyrosine kinase domain. Investing target one of the VEGF inhibitory pathway. And some other challenges like alcoholism, agent, chemotherapy, treatment toxicity, destroying patient life quality, and the residual zone that drug cannot reach, and then cancer stem cell rest until the residual to drive the recurrence. So every existing treatment is the right hand side and just solve one of the challenges. So we designed the wafer in a different way that needs a multi-model anti-cancer activity to target c-MET at cell 1 simultaneously the upstream of the signal to modulate the tumor proliferation. So in our one of preclinical study, the proof of concept in the preclinical study in the top right, on the right hand side, cell-blocker wafer drug are detectable at 6.5 centimeter and with high concentration within 3 centimeter. Compared to public glial wafer data in monkey brain, the drug can be detected at within 3 millimeters. So to be transparent, they are the different species, but the signal is very clear. So we start to establish our pipeline. It's not a single assay. The cell-blocker wafer for glioblastoma is heading to pivotal study, and can also carry through drug escalation and expand to pancreatic cancer in phase 1, and also the oral formulation. And more importantly, we discussed with FDA through Type C meetings, and we submit a new protocol for the pivotal design this year. And how the cell-blocker wafer works, we don't want to change the current standard procedure. It just fits into the standard surgical procedure that neurosurgeon already perform. After patient with recurrent tumor or tumor progression, neurosurgeon remove the tumor, cover the wafer onto the cavity, and drug biodegrades and drug release into the surrounding tissues. And then patient can continue after 30 days, then the patient can continue their post-operative adjuvant therapy. And here is the signal, clinical signal data. In our phase 2 add-on design, in recurrent glioblastoma, median survival reached 15.7 months versus roughly 6 to 9 months of the current standard. And in the biomarker group, patients with positive expression of EGFR or CMAP, survival expanded to 26.2 months. The response rate based on renal criteria version 1 range from 28 to 40%. The safety profile issue of gliadin wafer is that neurosurgeons avoid using it in about the seizure and healing issue. But in our data, neurological adverse reaction was markedly lower than using gliadin. But to be transparent, the rate of fever and pain were higher, but they were manageable and minor grade 2 were below. The competitive landscape of the gliadin wafer, the only one approval drug for the glioblastoma, we have the same indication and different in mechanism, safety profile, and the drug penetrate distance. But importantly, it has been approved by FDA as a regulatory pathway here, and also covered by the reimbursement, so it de-risks the reimbursement pathway for the surgery. And it's marketed. There are 100,000 glioblastoma patients annually globally, so the total market for the first line will be the 40% of the patient will use, and we are trying to address for the second line and obtainable in the US. In the US, there is around 10,000 per year. 40% of them will receive a resection, so the obtainable amount will be around 3,000 to 5,000 in the second line. And we are going to, we are fundraising $20 million to support this study. We will run 2 internal analyses. The second internal analysis can be used for the breakthrough designation and X-rated approval. We are activating 5 sites in the US by the end of this year and scaling up to 50 in Mexico, supported by our scientific advisor, Professor Chen from University. And here show you our management team. They bring 20 years plus experiences in international pharma, and one from FDA, director, and bring the regulatory viewpoint to us. And also our chief operating officer, developed online. Currently, it's the first line treatment for the pancreatic cancer. So we are fundraising $20 million to support the study, and it's an early signal of double survival. Why we are advancing to the pivotal study. And now we are trying to close the gate between the brain surgery and adjuvant treatment. Thank you very much.